Excellent. Welcome, everybody. My name is Amanda Johnson. I'm the Executive Director of the ASXL Rare Research Endowment Foundation. It's great to have everybody here. Happy to be wearing my Bainbridge-Ropers Syndrome shirt from Awareness Day this year for this presentation. So today we're going to be hearing from Dr. Meena Balasubramanian, who's one of the world's leading clinical experts in Bainbridge-Ropers Syndrome, and she's got a presentation to share with you all today. But to start, I have a couple of updates from our foundation, then we'll turn it over to her, and then I will help moderate Q&A at the end. So please put any questions in the chat and I will read them on your behalf and help moderate questions throughout the session. And you can put questions in the chat at any point. So a quick history of the R Foundation. We were founded in 2018. Our board is all parents. We currently have 5 parent board members, 2 of which are parents of children with Bainbridge-Ropers syndrome. We have 1 full-time staff person, that's me, and then we fill out the remainder of our organizational staffing and human resource needs with project-specific volunteers, several of whom are on the call here today. I see here in the participant list. We support research for all 3 ASXL syndromes. So that includes Bainbridge-Ropers syndrome, as well as Boring-Opitz syndrome, which is the ASXL1 mutation, and Shashi-Pena syndrome, which is the ASXL2 mutation. We funded over $550,000 in research so far, and host a couple of events to help bring the family community and research community together. We host the ASXL Research Symposium. That's the event for research professionals every year, including one coming up this July. And then every other year we host the ASXL Family Conference, which includes the family community. And I have some additional information about that coming in a couple of slides here. So the R Foundation really has a 2-part mission. The first is to support families through education, through programs like this, through our online resource library, through the family conference. And then our second part of our mission is really to build the research community and help develop that group that can do the work to find more answers, both clinically in terms of helping families understand what's coming next and how to manage their loved ones' complications and symptoms, and then also the basic research, understanding what the ASXL genes do and how they work. And at the center of that is family participation in research. And I'll have a couple of points here to share about how you can get involved in research and help drive both the research piece forward and continue to be an active participant in finding answers through research. We do have a couple of new resources that are available for families that I wanted to take time to call out in this presentation. The first is our ASXL Care Directory. We launched that on Rare Disease Day at the end of February. This is a family-sourced list of clinicians that includes both doctors and different kinds of therapists that have been recommended by families of children with ASXL-related disorders. So everybody on this list is somebody who sees at least 1 child with an ASXL-related disorder. So you can find that on our website, rfoundation.org/findcare. We are also looking for people to recommend other clinicians. So if you have people who are part of your child's care team who you would like to recommend to this list, you have the opportunity to do that from that page as well. We've also been building out our resource library. We've added 2 articles this year, one titled What Causes ASXL Related Disorders, that covers sort of the genetic basics of the ASXL genes and inheritance patterns, which we'll hear a little bit more about today. And then a deeper dive into epigenetics, which is a really complicated subject, but it's important to understand what type of disorders these are, how the ASXL genes work and their mechanisms. Helping families understand what that is and what that means will help you understand this long journey towards treatment and understanding additional information from more of the basic science side of things. So that's a new resource that's available on our website, and I encourage you to read it, probably not just once, but a couple of times. It's pretty dense subject matter, and but is really important for families to learn and be more familiar with. We also have our conference recordings from the 22 family conference, as well as additional programs like this, other topical webinars. That's all available on the resource library page. A couple of initiatives I wanted to point out for the year that the R Foundation is spearheading. We have a new program for newly diagnosed families that's underway. We've hired a part-time scientific advisor to help guide our future research investments. And she's also helping us build our landscape assessment now, which is sort of a document document that explains everything we know about ASXL-related disorders presently and helps define our research gaps that we can fill through funding and continuing to build the research community. We're supporting a couple of specific research projects, several that are relevant to the Bainbridge-Ropers Syndrome community. There's the puberty survey that is underway now. All ASXL3 families are eligible for that study. There's a new study coming soon specific to ASXL3. We'll be sharing some more information about that very soon, and also have some additional opportunities for families to give biological specimens in the United States, and we'll be sharing information about that soon as well. And as I mentioned, we have our research symposium this July in Boston, and planning to do another round of research grant funding before the end of the year. I also wanted to share just some information about the growth of our research community over the last couple of years. I know it can feel like things aren't happening fast enough, that we don't have as much information as we want or as we need. And it is a slow process, but we are making really good progress. So the chart on the left here is the number of researchers who are part of our foundation's research community. And you can see that we've more than doubled it since the founding of the organization in 2018. And then on the right is a picture of the ASXL Research Symposium participants in 2022. And everybody who's called out on the screen there is actively working on ASXL3 related research, including Dr. Balasubramanian, who's here with us today. So just wanted to share this slide quickly to remind everybody that progress is happening. A lot happens behind the scenes that we don't always talk about in big ways because it's slow and it's steady and we're chipping away, but there has been a lot of growth of the research community, and we're very grateful to continue to build that network. So a couple of important dates to point out as we wrap up this section here. Bainbridge-Ropers Syndrome Awareness Day, that's the shirt that I'm wearing today, was February 5th. That was the first one. We had a awesome participation from the BRS community in terms of fundraising and sharing information. Looking forward to the next one on February 5th of next year. Giving Tuesday, November 28th, which is the big opportunity for families to participate in online fundraising. Every year we've raised almost $30,000 the last 2 years through Giving Tuesday. So look for more information about that coming as we head into the second half of the year. And then the 2024 ASXL Research Symposium and Family Conference. This is the next opportunity for the family community to gather. Happy to share that we have some tentative dates on the calendar, July 19th through the 21st, which is the family portion of the meeting, on a US East Coast location. We're hopeful to have that finalized maybe even this week. So we'll put out an announcement as soon as that is firmed up and ready to share. But please pencil those dates in on your calendar. And finally, how do you stay informed? Would love for everybody on this call to join our email list, ourfoundation.org/email sign up. This is how you get information about specific research studies that you or someone in your family may be eligible to participate in, other specific updates, invitations to events like this. Joining that email list also allows us to see in our database how many families we have in each syndrome community. So it's really important to help get as many families as we can onto our email list. And also follow us on social media. Facebook and Instagram are our primary family channels. And we post almost every day across all platforms, and that's a great way to stay in touch. And finally, volunteer. If you're a volunteer, you get additional access to information. You have better ideas of what's going on. We need help with just about everything. As I said at the beginning, I'm the only staff person, and everything else that we do from an organization's perspective, we do through the help of volunteers, and could really use help with anything that you think you might be good at or interested in. I would love to chat with you and help you figure out where we might plug you in advancing our mission of finding more answers through research. So with that, I'm going to turn it over to Dr. Balasubramanian and let her introduce herself and share some updates for families. So thank you so much, Dr. Balasubramanian, for joining us. We're very, very glad to have you here. There we go. All right, we can see your screen. Perfect.
Sorry, I'm just gonna, I don't know why it went to the first one.
We lost your screen share there.
Let's try again. Ah, there we are.
Thank you.
Brilliant, thank you. And thank you, Amanda, for the kind invitation and introduction. So I hope everybody can hear me okay. Any problems, do give me a shout. So I'm going to be speaking more about ASXL3 related disorder. And you'll see I keep calling this ASXL3 related disorder as opposed to Bainbridge-Ropers Syndrome, and I'll tell you why. But just a bit of background about me. I'm a clinical geneticist in Sheffield, which is in England. And over the years, I have dealt with a lot of neurodevelopmental disorders. I'm a pediatric geneticist by background. And I think my interest in ASXL3, as with most things, started with a patient I looked after who's now an adult who had developmental delay, and we were trying to find the cause for his concerns. And this was one of the very early things we found in him, and that led to my interest, and since then it's sort of burgeoned from there. But what I thought I'll do is give you a bit of introduction about ASXL3, what the gene itself does, what do we know about the condition so far, and then talk a little bit about the familial variability that we have come across, because I think as families, you're clearly interested in that. If you do see quite a lot of your children involved in the slides I'm showing, thank you for all your contribution over the years. So as we know, ASXL3 is one of 3 genes from the ASXL family, and we know that de novo, meaning it started for the first time in the child, and truncating or splicing pathogenic variants in this gene results in a neurodevelopmental disorder, which is characterized by intellectual disability, developmental delay. There can be behavioral concerns, hypotonia, which is where you've got low tone and feeding issues. And often the disease mechanism is thought to be due to loss of function, which is where you've got haploinsufficiency or reduced amount of the protein. And if you think about ASXL3 itself, it sits on the long arm of chromosome 18. It is a relatively small gene compared to some of the genes I work with. So it contains about 12 exons, and it's got 2 conserved domains. And we think that it has a role in PRW-mediated deubiquitination. And it's enriched in a number of molecular processes, including transcriptional regulation, development, and proliferation. And it's expressed in a number of tissues, including brain, spinal cord, kidney, and liver. Now, as geneticists, we are interested in the tissue expression because, of course, this helps us correlate with what are the sort of phenotypes we're looking for. And so the background, as you'll all know, this came out of a publication by Bainbridge and Roper, who were the first and last authors of the condition, who suggested that it was a novel clinical phenotype that had very similarities to Bainbridge-Ropers syndrome, which we know is caused by ASXL1 gene. And we know that there was a shared phenotype with moderate to severe intellectual disability, with significant developmental delay, significant feeding problems, failure to thrive, and what they thought was a characteristic face. And as you can see, some of the children that were first reported in this paper. And there was also that sort of dystonic posturing, which they recognized as being a Bainbridge-Ropers posture, which was also seen in these children with what became known as Bainbridge-Ropers syndrome. And there was this nice work by Stephanie Beeler's group where they looked at fibroblasts from the patient and suggested that with frame shift or truncating variants with this gene, there was 50% reduction in the protein, suggesting that haploinsufficiency could be a disease mechanism. So this is where you got half the amount of normal protein. But of course, this is by no means a definite. So this is another thing we need to look at a bit further, because it can be a dominant negative effect as well as a haploinsufficiency. So that is something we need to further establish. But then, as I said, patient A is one of my patients who was found to have a de novo truncating variant in ASXL3. And what we then did was found, mostly from UK, a cohort of patients who presented with that sort of severe intellectual disability, poor or absent speech. They had a variety of behavioral concerns, including autistic traits, And what we described was a distinctive facial appearance with poor tone and feeding difficulties. So this was at the time the largest cohort of patients with ASXL3 pathogenic variants that was published. And then just to look at some genotype-phenotype correlation, we were able to show certain mutation hotspots, especially in exon 11 and exon 12, where there seem to be recurrent variants reported. And so since then, it sort of got on from there. We started to look at more in-depth ASXL3 phenotypes and established an international collaborative study. Quite a lot of the contribution came from GeneDx as well, where they found patients through developmental delay panels and whole exome sequencing. And we were able to identify 47 patients with pathogenic variants in ASXL3. And of course, that group keeps growing. And as Amanda and I were discussing earlier, ASXL3 is one of the top hitting genes, one of the top 10 hitting genes when you think about developmental delay workup. And as genome sequencing is getting cheaper and more accessible, we're finding more and more of a spread of phenotype when it comes to ASXL3. And this is just some of the papers we worked on. So we look at some of the phenotype that we come across. If you look at weight at birth, of course, this is not a IUGR condition. What I mean by that is they're not always small for gestational age, but because of the feeding difficulties later on in life, it can be that they have poor weight gain. And then again, similarly with the height, when you look at postnatally, there can be a reduced height as they get older as well. And the head circumference at birth, again, this is not a microcephaly condition, so they're not born with a small head, and often, there's proportionate short stature or reduced growth, mostly due to the feeding issues. So again, it's important that these feeding issues are picked up early and addressed with ASXL3 related disorder. And then learning difficulties, I think this graph has to be redone again, because as you can see, when we started ascertaining our initial ASXL3 cohort, we found that quite a lot of them had severe to profound developmental delay and intellectual disability. But I think now we see that there's more of a spectrum. And if you read the graphs now, you would see more in the sort of mild to moderate end of the spectrum growing. And then skeletal features was something I picked up quite early on, because they seem to have like a marfanoid habitus with arachnodactyly, where they have long fingers and toes, and they also had joint flexions or contractures, and narrow feet, delayed bone age. So we started to characterize that a bit further. And then behavioral problems, as with any neurodevelopmental disorder, there is a spectrum. And what we found is there can be certain specific features such as hand flapping, self-injurious behavior or aggression. And quite a few of them also had this formal diagnosis of autism spectrum disorder. But of course, not all of them reached enough of that threshold for a formal diagnosis, depending on which testing you did. So this is just a summary of all of the features. And as you can see, I was mentioning feeding difficulties, hypotonia, the speech delay, intellectual disability. These are the things that we come across quite frequently. Seizures has been reported, but I don't think it's a hallmark of the condition. Unlike some of the other neurodevelopmental disorders, this is not an epilepsy condition as such. But it is something we need to look into a lot more detail. And then there's teeth overcrowding. They can have hypodontia, where there's a reduced number of teeth. So again, dental care is important post-diagnosis. And then this is just showing facial appearance as it evolves over age. You can see this is quite important for us in terms of recognition, because it's important that we pick this up early, or at least suspect the condition, even if we are doing the test early enough these days. And then this sort of dystonic posturing, which I mentioned earlier with Bainbridge-Ropers syndrome, where the elbows are held in that sort of flexion extension position. These are subtle clues which might help us reach a diagnosis when we see the patients for an initial workup. And then, as I was saying earlier, we're starting to see quite a lot of the adult cohort coming through, where they present with mild to moderate intellectual disability and are often either in assisted living or able to work independently in certain aspects. And then this is just to show that the facial features can be easy to pick up, but at the same time can be quite difficult to pick up because they are not distinctive. So sometimes we talk about pathognomonic facial appearance, or things that we can pick out when we go to the waiting room in clinic, and we can pick out what condition child has, like Kabuki syndrome, for example. I wouldn't put that in that ballpark. And the more we see ASXL3 related disorder, the more I think there isn't a distinctive facial appearance. But along with everything else I've just described, we should be able to identify this early enough. In terms of variants reported in the study, again, there are a number of truncating, frame shift, nonsense variants. A handful of missense variants have been reported, but this is something that we want to characterize much further, because there was a paper that talked about biallelic missense variants being associated with congenital heart disease. But again, that's not borne out with further patients that we have seen with ASXL3. And then this is just to show the distribution of the variants. And as I was saying, there are a couple of, I wouldn't call it mutation hotspots, but exonic regions such as 11 and 12, where quite a lot of the pathogenic variants sit. And then just to talk about some quirks within ASXL3, so to speak. So there's Mosaicism and ASXL3 related disorders. So we found 2 families where there were non-twin siblings who had de novo pathogenic variants. So this is a case of germline mosaicism, where the parent might be carrying it in their gonads, so sperm or egg, without it being present in the rest of their tissue. And so the question was there an increased risk of gonadal mosaicism? And I don't think, compared to some of the genetic conditions we see with a very high risk of gonadal mosaicism, that's true. But again, this is something we want to study a bit more further, especially when we're thinking about familial inheritance. And then this is another case of mosaicism. So this is low-level mosaicism, about 30 to 35% in the tissue. But of course, we are not able to say what was the tissue-level mosaicism in the brain, which is what depends on what the phenotypic characterization is. That this is a child that presented with no speech, self-harm and aggression, overcrowding, severe dental extraction, so had all the hallmarks of ASXL3 related disorder. And we found that it was only in a proportion of the blood sample on the DNA that we tested that the ASXL3 variant was found. So this is another case of tissue level mosaicism resulting in ASXL3 related disorder. And then moving on to familial ASXL3, which I know is the main reason we put this session together. And one of the reasons I was saying I don't call it Bainbridge-Ropers Syndrome, I'd rather call it ASXL3 related disorder, is because as it was published, Bainbridge-Ropers Syndrome was a very severe phenotype where they had the hallmarks of similarities with the Boring-Opitz syndrome. But what we're finding is a much more milder version of the condition, especially as we're describing more familial cases. So we can have a discussion later on about what should we be calling this, but ASXL3 related disorder seems to be a good way to start. And so we've seen intrafamilial phenotypic heterogeneity, and we've shown heritability. And what we did was publish this as a familial Bainbridge-Ropers syndrome. So this is one of the families where the little boy came to medical attention because he was non-verbal and had intellectual disability. He also presented with feeding difficulties, sleep issues, and a dilatation of the subclavian artery, but he was asymptomatic. And one of the questions we had in that paper was, should we be doing more cardiac screening? I don't think so, apart from routine. But yeah, it is something to be thinking about. And what we found was this frame shift variant was also found in the father, and he had attended a special needs school, had been diagnosed with ADHD when he was young. There was some difficulty with writing and processing information, and he looked somewhat similar to the child, as you would expect, because it's a parent and child. But then, we were convinced that this was contributing to the phenotype in both the father as well as the child. But of course, the child had come to medical attention earlier because he had a more severe presentation. And then again, this is a fascinating case from Ireland where this family presented with a little boy, again, quite a severe end of the spectrum. So he had global developmental delay, for which he was seen in the genetics clinic. And then it transpired that the sister, who was much more milder, also had the exact same phenotype. Mother had actually gone to a special school previously, but was managing in a supermarket, was able to live independently and, of course, look after these children. So again, thinking about intrafamilial variability. And just to point out, all of these diagnoses came through whole exome or whole genome sequencing. So it's not like we'd missed another alternate diagnosis in the more affected siblings. And again, talking about that sort of dystonic posturing and the way he's holding his legs. So obviously extremely hypermobile here. And then this is another family from California, where the daughter was referred because she had intellectual disability, epilepsy, and autism. And the mother had a university degree and was obviously managing fine. And this was a maternally inherited pathogenic frame shift variant, which was deemed pathogenic in this family. And then we've come across this Greek family quite recently, where the child was referred because he had intellectual disability, autism, absent speech, and poor eye contact. And actually, what we found was the father had a very similar facial appearance and mild ID. He was working as a storekeeper. And going back at the history, it became apparent that his father, that is the child's grandfather, also had delayed speech and very, very mild ID. So of course, we think that this is what is that sort of phenotypic variability within this family, but this is the explanation. And this is a family that we're collecting cells from to actually study that sort of episignature to say what could be the variability here, or what could be contributing to the variability here. So just to say, in terms of our research, we're collecting large cohorts of patients with ASXL3 related disorder, looking at the clinical data set, and hoping that we can talk a little bit more about the milder phenotype, which is emerging. I talked about the gonadal mosaicism, the mosaic pathogenic variant resulting in a fully penetrant condition, familial variability within ASXL3, and hopefully get a better understanding of the natural history of ASXL3 related disorder, particularly with description of more adult patients. Because if you think, most of the neurodevelopmental disorders are quite pediatric heavy, but as most of these children are now surviving to adulthood, we need to understand what is the longitudinal data and what's the natural history for adults with ASXL3 related disorder. And this is work that we did previous to the R Foundation with Unique Patient Support Group, where we did this work on ASXL3 Patient Support Group leaflet. And of course, this gene review, which I think can be quite helpful, especially when a new diagnosis is made for clinicians and families to see, because this is quite focused on management and what should we be doing at early diagnosis. So that can be quite helpful. And then I wanted to bring in Emily Woods, who's my genomics fellow, but also more recently started as a trainee, an official trainee in the clinical genetics department at Sheffield. I don't know, Emily, if you're there on the call and can introduce yourself and take it from there.
Thank you. Can you hear me? Just checking that my yeah, brilliant. Thank you. So as Meena said, my name is Emily Woods. I'm a doctor with a background in paediatrics, but I've been working in clinical genetics and with Meena alongside the ASXL3 work. So we're establishing a new research study at the moment, which I'd like to speak a little bit about, tell you a bit more information if that's okay. And a gene registry is part of that. So for patients and families with ASXL3 related disorder. But alongside the research study, we're also hoping to write up another paper for another medical journal. So similar to the paper that we've already published with the familial cases. And obviously the aim of this is to increase the numbers of patients that have been published and described in detail in the literature. Because obviously at the moment there's not very many, so it helps advise clinicians and it helps increase our understanding of the disorder as well. So at the moment there are approximately 100 patients described in the literature, but obviously there are many more, but they've just not been published. So there's real value in collecting a large patient cohort to publish, and then we can compare the specific gene changes with the individual clinical features as well. So as Meena mentioned, the individuals who have the same gene change can have very different features to their relative, so the variability in families. So it'd be really good to understand that further. So if anyone's interested in being a part of a new publication, we'd really appreciate that. So this poster, so this relates to the research study. So we're hoping to recruit people of all ages, so children and adults who've got a confirmed diagnosis of ASXL3 related disorder from all over the world. Although we're in Sheffield in the UK, we are wanting people from all over, including the US. So the study would involve an initial clinic appointment. So if you're not in the UK, then it could be a virtual appointment. If you're in the UK, then it can be face-to-face, and we'd essentially ask lots of questions about you or your child's health, including things like development, behaviour, any results of investigations, and then potentially ask your doctor to expand on anything that we need in more detail. And then we'd go out to send an annual questionnaire every year just to see how things are progressing and how things are changing. So it's a longitudinal study, essentially trying to understand the condition over time, and that's not been done before or published before. So as part of this, we're also looking for any blood samples or skin samples to be sent for further functional work to try and understand the disease mechanism in more detail, and this will allow us to understand the specific gene changes better as well. So that's all a part of the study. Yeah, we're hoping there's going to be lots of interest, and if anyone is interested, feel free to email me, and I'd be more than happy to give you a bit more information. At the moment, we're still just waiting for confirmation of ethical approval, but hopefully in the next few months we can start rolling things out. I think my email address will be on there, but it's emily.woods2@nhs.net. But yeah, there's some ongoing lab work as well, which Meena can inform you about.
Thanks, Emily. So I suppose from just to add to that, Emily's our main portal of contact. I've got I'm spinning so many plates that please contact Emily if there's anything you're interested in. But of course, I know most families are, keen or curious to find out, is there ever going to be a therapy for things like this? So of course, one of the things I'm also focused on is looking at gene therapy in a broader sense of the word for neurodevelopmental disorders. One of the other genes I work a lot on is HNRNPU, which is a epilepsy gene. But of course, we've got a couple of projects on the go looking at can we find a gene therapy? And if the idea or the theory is that if it is a haploinsufficiency and if you replace the protein, is that going to make things better? Very early days, of course, there's a lot of work that's still required, but it is something that's ongoing. And as Emily was mentioning, looking at an episignature, Amanda, you mentioned this about episignature, and we know that ASXL1 and 2 seem to have a signature. So just trying to see whether 3 does too. And then we talked about the natural history study, but also looking at missense variants, because ASXL3 is one of the top hitting genes. You also find a lot of missense variants. And at the moment, we sort of draw a line saying, no, the missense variants are not contributory. But I think that's a very naive way of looking at it. And we need to characterize that further and say, could missense variants be contributing either to a milder phenotype or perhaps a different phenotype? So that's work in progress. Yeah, I'd like to finish off by thanking all my colleagues, Shaida, Sherwani, who had worked on the previous ASXL3 study, as well as all my funding bodies. I'm happy to take any questions. I wanted to leave enough time for discussion, so hopefully that's okay. Thank you.
Yeah, thank you. So Emily, I'm going to come to you first and just make sure families understand when they reach out to you. It sounds like they should have their genetic report on hand when they reach out, and do they need any other information when they email you?
So not necessarily. What we will double check is that families are happy for us to contact their clinician as well. So they don't need to have the specific details. We can get in contact with your clinician and get any of the specifics from them, really. It doesn't need to all come from the families directly.
Okay, thank you. And we'll make sure we share your email address with everybody's who's here today in our follow-up communication, so folks can reach out to you directly. So we do have a couple of questions in the chat that I can start with here. So one question, is there any correlation between severity of symptoms and the location of the gene mutation?
Yeah, so great question, something we get asked all the time. We use the word, very broadly speaking, genotype-phenotype correlation. And I suppose one caveat with any of these conditions, including ASXL3, which is commoner than most genetic disorders, is we just don't have enough numbers for us to confidently say that there is a genotype-phenotype correlation. But traditionally, yeah, thinking about it, exon 11 and 12 mutations, there doesn't seem to be a particularly different variability in the phenotype. Emily, you've looked more recently at the literature, so do come in.
Yeah, so there's not any correlation that's known at the moment, but as Meena said, it's something that we'll be looking into in more detail as part of the research study.
Thank you. There's a question about family groups in the UK, and Ruth, you're on, isn't it? I don't know if you wanted to come in and say anything about.
Yeah, it's just something that we would know. It's a long-term thing. We've been trying to get funding to set up a really good group in the UK, but it's not something that we've actually managed and as yet. But anybody that is interested can contact me, and we can see if anyone's got any ideas. We're just talking about, I mean, now that we've got things like Zoom and Teams and stuff, it will be a lot easier. So we don't actually need to find a venue. But I'd definitely be interested in heading that, you know, if we have enough people that would be interested, yeah.
Amanda, you're muted, I think.
Sorry. I was gonna say, Ruth, what's a good way for people to reach out to you if they are also based in the UK and would like to be in touch with you about a UK local group? Oh, now you're muted, sorry.
I'm happy to put my email address in the chat for anybody if they want it.
Great, thank you. Okay, a couple of additional questions here. Is chronic pain a common symptom seen in ASXL3 related disorder from your experience, Meena?
I don't think it's unique to ASXL3 related disorder, and we do see quite a lot of children with neurodevelopmental disorders who have chronic pain. And I suppose the other difficulty is communicating pain, isn't it? So I can sit in clinic and often hear families saying he gets very frustrated, but I don't know what is the reason. And sometimes it can be chronic pain. And I know with my other hat on, where I don't want to scare you guys, but you know, we've had a number of children, because my other big interest is bone genetics, and I do a lot of work on brittle bone disease, osteogenesis imperfecta, and there have been not ASXL3, but some other neurodevelopmental disorders where actually it has happened that there's been issues around chronic pain or just acute pain, which has led to quite a lot of anxiety, and often these children have fractured. So sometimes it can be difficult to find out what is the source of the pain, but I don't think it's unique to ASXL3 that chronic pain is more heavily described in this.
Thank you. Another question, from your experience, as children grow, are you seeing changes in hypotonia and facial features? Are they getting more severe or more notable over time, or perhaps it goes the other direction?
Yeah. Again, from the limited number of children that we followed up who have now become adults, I would say, yes, you're right. The hypotonia often, you know, as does happen with most pediatric conditions, it results in reduced tone and then eventually increased tone. And that's where you get that sort of spastic position, the flexion extension that I was describing. And that's often because of increased tone. But what you hope is these days, with increased access to physiotherapy and occupational therapy, hydrotherapy, etc., that's sort of taken care of as best as possible. And again, what was the other thing about there was the tone and then
facial features.
Facial features. Again, as I was showing you with some of the images of evolution of facial features, yes, you can see that it becomes more pronounced as they get older, but I don't think that's always the case. And this is where the familial cases are quite good, especially when we've seen the parent and the child. I don't think it's a case of, yes, in all situations, the facial features become more pronounced. But I do think that is quite a good exercise to be able to follow up facial appearance over time.
Thank you. So a couple of questions related to feeding difficulties and cyclic vomiting. So have you heard of any solutions around solving cyclic vomiting for kids with BRS? And specifically around that relating to the ability to gain weight?
Yeah, again, good question. And it is something that we come across quite a lot, but I'm afraid I don't have a solution as such. But what we often say is, and this is something I would say to families that I see in clinic, make sure that if there are feeding difficulties, they're picked up early. If there are interventions that are required. So sometimes families would ask me, do you think a gastrostomy would be helpful? And I would say, yes, a fundoplication and a gastrostomy would be helpful. And I would say, yes, if it means that the vomiting can be controlled and it would result in better growth. It's better to go for these interventions rather than hang on and hold on until things get really worse and a significant loss of weight. So this is where that management guideline for the gene review, I've sort of said, pick things up early and try and get intervention early if possible. But of course, it's weighing that up against, you want to see if the child does improve on its own and the feeding difficulties do resolve. So it's getting that balance right. But it's a bit like Russell-Silver syndrome. We say don't wait and wait for the child to grow, because we know there is a genetic reason for these issues. So you might as well intervene and try and fix things. Well, I say fix, try and sort things out early if you can.
Thank you. And then an additional question related to that. Do you have any hypotheses as to why feeding difficulties are common in Bainbridge-Ropers syndrome?
Again, I don't think they are specific to ASXL3. Most of the neurodevelopmental disorders do have feeding difficulties as a significant component of the phenotype. And I think it's down to possibly the tone, possibly the swallowing difficulties that these children experience. And so it's part of that spectrum. I mean, one of the things, Misha Duker, who works on ASXL, we talked about was actually looking at the generating neurons from the gastrointestinal system and seeing what's happening, whether there is a sympathetic or non-sympathetic problem with the nervous system, and that's what's contributing. And that'll be a fascinating piece of work to do, because I suspect it is to do with the neuronal signaling. Because if you think about peristalsis and how the food enters the body and gets transported, obviously there's a lot of neurological involvement in there. And I think that is what is the bottom line, or should I say, the explanation for most neurodevelopmental disorders. And I don't think it's specific to ASXL3.
Great, thank you. So another question around communication, a couple of communications around communication. Have you seen any children whose vocabulary has grown over time, if perhaps they started, non-speaking or nonverbal?
Yes, again, it's, yes, I have seen that. And but again, it's getting that balance right between trying to put lots and lots of intervention in place to have a couple of words, as opposed to, so what I always encourage families, and I'm conscious I'm speaking to a lot of families here, is I always encourage to get their child to communicate in some form of the other, whether it's PECs, whether there's iPads, or, these days there's lots of fancy ways of communication. And I always encourage families to say the frustration or sometimes the behavioral concerns come in because of that inability to communicate their needs. And it's trying to get a form of communication that works, whether it's words or non-verbal communication. So I always encourage families to not just focus on the verbal communication, but also look at the non-verbal communication and try and work at ways that would improve that, whether it's Makaton, whether it's PECs, whether it's another form. But I think certainly speech therapy, and thinking about speech therapy, it's not just for speech, but also for swallowing and safe swallow and those sorts of things, isn't it? So it is important to get that in early and make sure that there is subsequent follow-up.
Thank you. There have been a couple questions around communication, and just want to make everybody aware that on our YouTube page and on the ASXL resource library that I shared earlier, we did a session at the 2022 conference specifically around communication that included using an AAC device. And I know there's a question here about sign language, and sign language was addressed in that session as well. So would refer families to the resource library to check out some of those recorded sessions from the conference. There's also one presented by a gastroenterologist who talks about cyclic vomiting, to go back to the previous line of questioning. And we know we've heard from at least one Bainbridge-Ropers syndrome family that some of the recommendations that were made in that session were life-changing for their child in terms of helping them manage cyclic vomiting. So encourage everybody to check out the resource library where some additional information may be helpful to you. Okay, so another question here. Have you seen any improvement with hormone growth injections in any of your patients that you follow?
Not particularly. I can.
The question would be when might that be indicated if relevant?
Yeah, and I can speak about this more broadly as much as specifically for ASXL3. What we know is that when there is a genetic explanation for feeding difficulties or a small stature, or although ASXL3 is technically not a short stature condition, growth hormone can add very little benefit. So, and I'm not an endocrinologist, but this is my experience, is that they can be, okay, a few centimeters of increased growth, but it's a lot of hassle and a lot of pain to put a child through that. So, and often where it does work is where there is growth hormone deficiency. So if your child has short stature, it would be worth getting an endocrine workup and seeing if there is growth hormone deficiency, in which case certainly there is a role for growth hormone supplementation. But as with most genetic conditions, if you're just giving growth hormone in case the growth improves, then often what you find is that, yes, there will be a short-term gain with height, but it's not going to result in, the adult height is not going to be much more variable. And in fact, my first patient with ASXL3 was indeed really tall. So, it's not a short stature condition. And I don't think growth hormone would be uniformly prescribed in this group. So it's where there is growth hormone deficiency.
Great, thank you. So to go back to some of the familial inheritance line of questioning. So one of the questions is there any testing available for parents to verify if a future second child could also have ASXL3? And I wonder if this might be a good opportunity just to reiterate what you explained earlier about what gonadal mosaicism is, just to help make sure everybody understands what that is when you're talking about that.
Sure. And also just to also reiterate that the study is for all of them. So we're not looking at just de novo or just inherited variants. We want to be able to look at ASXL3 as a whole spectrum. Going back to the specific question, it depends if it's your first child with an ASXL3 related disorder and you're thinking about the second child and you want to know what is the recurrence, then yes, is it de novo is the first question, as in, has it started for the first time in the child? Have you both been tested and negative for it? And in this case, you would have a small risk of gonadal mosaicism. And when I say small risk, it's less than 1% chance of this happening again in the second pregnancy. And where is that 1% coming from? Is because there is a possibility that a proportion of the sperms or eggs might carry this genetic change in ASXL3 without it being present in the rest of the parent. So that's where that gonadal mosaicism risk comes in. With most genetic disorders, we would say it's even lower than 1%, not 0.5%. And there's a nice study called PrecCare, which had done quite a lot of work into that, looking at semen samples and ovarian biopsies, etc. But then if you look at, so yes, in terms of testing, if you both been tested that as parents and it's de novo, then I don't think there's anything further to do at that point. You could have testing during the pregnancy. Of course, you naturally conceive and have either a chorionic villus sampling or an amniocentesis to find out if in the second pregnancy, if the embryo carries the same genetic change or not. But that would be done more for, want of a better word, reassurance. Just to bear in mind, in any couple going through a pregnancy, there's about a 2.5% chance of a problem happening. This is your general population risk. And what I always say to families is the 20-week scan, whenever it's done in the US, is called an anomaly scan because that's what we're trying to pick up. So yes, the risk of having a recurrence with a de novo ASXL3 variant is much lower than your general population risk, which is 2.5% for any couple going through a pregnancy, just to put things in context, because risk is very relative. And especially when you've got a child with an ASXL3 related disorder, it might feel like the risk is a lot higher. With the familial cases, of course, what I'm describing here is where the parent carries the exact same genetic change as the child, and then it's a 50%. You're going to pass on the faulty copy or the normal copy of the gene, for want of a better word. So it's 50-50, heads or tails, and it doesn't matter whether it's a girl or a boy. So you can go from less than 1% to up to 50%.
Thank you. So another question here, is there any combined symptom correlation? So for example, are patients with seizures more likely to have more severe hypotonia or more severe ID, et cetera?
Yes, that's a good question. And I think to a certain extent, yes, we see that. Again, as with any neurodevelopmental disorder, that where a child has, and I wouldn't call just epilepsy or seizures as a risk factor, but it's uncontrolled epilepsy or uncontrolled seizure disorder, or where you're requiring multiple medications to manage the seizures, then there will be a knock-on effect on the development. And one of the things we always say with seizure disorder is to be able to manage the seizures in a fashion that you're not having a line of multiple medications, which is going to completely knock down the child, sort of thing, you know. So it's getting that balance right between managing the seizures, but at the same time, making sure that developmental progress happens. As I said in my presentation, ASXL3 is not a seizure disorder as such. Even in the cohort, we looked at about a third, if that, had seizures, and most of them responded well to standard anti-epileptic medications and monotherapy. So again, it's something we need to look into a lot more detail, but I don't think on the face of it, from the evidence we've got so far, it is a seizure disorder condition. But yes, you can imagine that with significant seizures, you will have more significant problems with development, especially if it's not completely controlled.
Thank you. So that's it for questions in the chat. Does anyone else have any final questions? Oh, here's one here. Okay, so this is going back to the familial inheritance. Just to be clear, for de novo cases where the parents don't have any indication of ASXL3, would IVF or alternative ways of conception help eliminate the risk of gonadal mosaicism?
So when you think about alternate ways of conception, I'm assuming you're sort of referring to pre-implantation genetic diagnosis. I mean, often when we talk about recurrence, we say, you know, like I said, you know, there is a chance it can happen again. It's very low, but there is a chance. And I was talking about the relative risk. But we say always do nothing. You can have a donor egg or sperm, which eliminates that risk, you know, to a certain extent. You can have pre-implantation genetic diagnosis. So this is where you have, for those of you that aren't familiar with PGD, you have a bit like an IVF, but with the added step of genetic screening. So the sperm and egg are fused together, you grow it to an 8-cell stage, you take out one cell, examine to check whether the ASXL3 genetic change that was seen in your older child is present. And while you're at it, you also check for chromosomes, and then you only put back those embryos that don't carry the ASXL3 genetic change and have normal chromosomes and look healthy. So as you can imagine, there's a lot of variables in there. And then you hope that a pregnancy takes. Now, depending on where you are, PGD can be expensive, but also it can be a bit of a roller coaster ride. You know, there's 1 in 3 chance that you can end up with a successful pregnancy at the end of that whole exercise. But it is available. And it is something that I know some countries practice a lot of and do a lot more as opposed to other countries. In the UK, it's not usual to have PGD for such a low, because the risk cutoff is 10%, I think. So yeah, it's you wouldn't be eligible for PGD in the UK or under the NHS, should I say. But I know different countries practice slightly differently. So PGD would be an option. But again, talking about relative risk, you know, why would you do that sort of thing?
Great. Thank you.
But we're here to provide the information.
Yes, yes, exactly. Wonderful. Okay, another inheritance question. In this scenario, the father of a fraternal twin, one got diagnosed, waiting on the other child's result. What is the probability of both having it. And I assume it is having ASXL3 related disorder.
I suppose the main thing is to find out if the other child is got any concerns. And if it's a non-identical twin, you wouldn't have thought that there is going to be any higher risk, like your sibling risk, basically. But I suppose it comes down to whether the other twin has got any problems themselves with development or other issues.
Thank you. All right, and I think we'll leave it there. Oh, sorry, one last question. Well, last one under the wire. Any ASXL related disorder symptom severity combination independent of seizures? Oh, Lauren, do you want to come on and ask that? I think I didn't interpret your question all the way appropriately.
Hi, Meena. How are you? Can you hear me?
Yep.
Yes, good, thank you.
Yes. Sorry, that was my previous question about like symptom correlation often seen together. I didn't really mean to make it seizure specific, but I was wondering if like increased ID is correlated to increased hypotonia or decreased verbal capabilities, or if you're seeing any two symptoms that kind of traject over the same line.
Sure. Okay, I see what you mean. Yes, I think there can be a little bit of that correlation that happens as you've just described. You can have hypotonia with hypermobility because they often go together. You can have intellectual disability with developmental delay and speech delay because they often go together. And I mean, this is the sort of things we want to tease out with a larger cohort, because we had a large enough cohort, but even with that, you need much bigger numbers. And I think ASXL3, fortunately, is one of those conditions where we can get large enough numbers to be able to tease out that level of detail. And that is why, I got Emily on the case and said, look, let's look at it in a lot more depth, because that sort of in-depth phenotyping should be able to give us that sort of nuances that we want to be able to better understand.
Great, thank you.
That's fine. Right, so we'll leave it there. So in follow-up, the recording of the session will be posted on our YouTube channel and also put in the ASXL resource library. That's another great place to go and check for some of these additional care management questions around GI issues and communication. Wanted to thank Meena and Emily for joining us today. Really appreciate it. This has been incredibly informative, and I think this will be a great resource for families to come, including those who couldn't be here with us in person. And just want to invite everybody to please join our email list and follow us on social media so we can help get you great information about additional study opportunities like the one Emily described today, and make sure you hear about the 2024 conference date and location as soon as we publish it, hopefully this week. Thank you, everybody. Appreciate it.
Thank you.